राइट जी। गुड इवनिंग जी, गुड इवनिंग जी, गुड इवनिंग जी। आई एम हेयर ओनली भाई जी, हेयर ओनली। कहाँ जाऊंगा जी आपके बिना। डॉक्टर गौरव जी, डॉक्टर विघ्नेश्वरन जी, डॉक्टर हेमंत सिंह जी, डॉक्टर प्रतीक जी, यहीं पे हूँ भाई जी। वेयर विल आई गो, कहाँ जाऊंगा आपके बिना। राइट, ओके 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 ओके, थैंक यू। चलो जी, व्हाट सिटी यू गाइज आर फ्रॉम। इस समय आप लोग कहाँ पे हैं भाई। मैं तो अमृतसर में हूँ, मेरी कुल्फी जमी पड़ी है लिटरली। इट्स सो डैम कोल्ड आउट हेयर, खतरनाक वाली ठंड है यहाँ पे। गुड इवनिंग जी, गुड इवनिंग जी, गुड इवनिंग जी। इसको मैं सामने रखता हूँ अपने। राइट, वेरी क्विक रिविजन। ओके, गुड इवनिंग जी, गुड इवनिंग जी। ओ भाई साहब, द ऑर्थोपेडिक यू वांट। सर अपना सही नाम बताएंगे। गुड़गांव, फजिल्का, लखनऊ, सब जगह सेम ही हाल होंगे, सब जगह सेम ही हाल होंगे। बट अमृतसर इज लाइक नॉर्थ ईस्ट, तो यहां तो कुल्फी जमी पड़ी है। चेन्नई इज गुड यार। विघ्नेश्वरन, चेन्नई इज गुड। सूरत इज ऑल्सो ओके, है ना। ओके, सो दैट्स अबाउट द लाइव बैच जून 2026। ईश्वर करे आप में से किसी को भी इसकी जरूरत ना पड़े। ओ माय गॉड, कारगिल। ईश्वर करे आप में से किसी को भी इस बैच की बिल्कुल भी जरूरत ना पड़े। करेंगे ही करेंगे, ईश्वर किसी को जरूरत नहीं पड़ेगी इस बैच की, बट आपके जूनियर्स के लिए फाइन। देखिए जी, हमारी स्टार टीम सब दिख रहे हैं यहाँ पे आपको, राइट। सी, ओके, सो आशीष सर उनकी मतलब लीडरशिप में वी आर स्टार्टिंग द जून 2026 FMG बैच। दीज आर द फैकल्टी मेंबर्स जो लोग रहेंगे, राइट, क्लास के लिए, राइट। ऑनलाइन बैच, प्योरली ऑनलाइन बैच। ओके ओके, सो ये हार्ड कॉपी वगैरह सब इसमें मिलेगी, क्वेश्चन बैंक वगैरह सब, ऐप का एक्सेस सब मिलेगा इसमें, राइट। नाउ without wasting any time, let's quickly move to let's quickly move to the orthopedic revision first. ऑर्थोपेडिक रिवीजन करने के बाद हम लोग तुरंत आपके साथ थोड़ा बहुत रेडियोलॉजी का रिवीजन करेंगे, राइट। नाउ सी हियर, सो फर्स्ट इज स्पॉन्डाइलोलिस्थेसिस। स्पॉन्डाइलोलिस्थेसिस, डॉक्टर साहब प्रतीक जी 2 घंटे की क्लास है, 2 घंटे में जितने टॉपिक हमारे हो पाएंगे उतने करेंगे, राइट। So let's say we have started at around 5 o'clock. So by around 7 o'clock I'll end the class. Fine. 7 बजे के बाद मेरी एक दूसरी क्लास भी है, so I'll have to end the class at 7 o'clock. Right. Now spondylolisthesis. So most commonly it is at L5S1. Most commonly it is at L5S1. 2 साल पहले याद होगा क्वेश्चन आया था, सेम ये वाली फोटो दिखाई थी और पूछा गया था कि कौन से लेवल पे लिस्थेसिस है। Spondylolisthesis is slippage of one vertebra over the next vertebra. So L5S1 commonly किस डायरेक्शन में होता है? Commonly it occurs in the anterior direction. एक मिनट विघ्नेश्वरन जी, let's say if I speak something in Hindi, you don't have to worry about it. I'll immediately translate that to English, right? Don't worry. Okay, so L5, this is the most common type. Most common type. Yes, yes, yes. Only the important, only super important one. So you see here, L5 is slipping over S1. L5 slipping over S1. So you see here, this is, अब मेरे हिसाब से ये वाली फोटो आप अपने मन में बिठा लो, right? This is important. This is L3, L4, L5, and L5 slipping over S1 is the commonest. Is there any kind of lag? Dr. Akhil Reddy sir is saying that there is some kind of lag. If there is any kind of lag, please do let me know. Now this is when L4 vertebra is slipping over L5. So this is L3, L4, L5. So this was the image which they asked around 3 years back. L4 slipping over L5, right? Now on the lateral X-ray, on the lateral X-ray, what do you get to see? You get to see collared Scotty dog, collared Scotty dog. Okay, right, G, right. On the AP view, what do you get to see? On the AP view, what do you get to see? You get to see something which is called as inverted Napoleon hat. Inverted Napoleon hat. Okay, right जी, right. नेपाल नेपाल में तो कुल्फी भी पत्थर बन गई होगी. Right, so spondylolisthesis. Now again, there is a common question which they ask, and there is a source of confusion. So most common site is L5 S1. L5 slipping over S1. Now prolapsed intervertebral disc. Most common is L4 L5 PIVD. L4 to L5. Fine. Now here spondylolisthesis L5 to S1. Now there is something special. Fine. Now this kind of fracture is called as hangman fracture. So hangman fracture is where C2, it will slip over C3. Fine. And then there will be fracture of C2. So this is atlas, this is axis, right? So C2 will sustain a fracture. Now see buddies, name is hangman, but nobody hangs like this, right? Yes. Right. Now see here. This is the common mechanism of hangman fracture. That is head hitting the dashboard. Of the car. That is common mechanism of hangman fracture. Now car dashboard is very notorious. So car dashboard, what injuries are common? First, posterior dislocation of hip. Then posterior collateral ligament injury. At the knee joint. That is common with car dashboard. Is that someone from you calling? Sorry, there was some call. I'll have to. Okay, so these are the common injuries which occur with car dashboard. Sorry. Okay. Now, so yes, I believe now you can identify this fracture. Can anyone of you tell me what is this fracture, please? Now, what you see over here, C1 is perfectly fine. It is the C2 which is fractured. So there is fracture of C2. Again, these are just the images of hangman fracture. Right? Odontoid view. Dr. Hemant ji, नहीं कौन सा पूछे, डॉक्टर अन्ना. C1 fracture is seen in odontoid view. यही आ गया जी, ओपन माउथ odontoid view. मेरी वॉइस कट हो रही है. ये हमारे डॉक्टर साहब, डॉक्टर एस्पायरिन साहब बोल रहे हैं कि मेरी वॉइस कट हो रही है. इज इट सो? जस्ट गिव मी अ मिनट, लेट मी चेक. डॉक्टर साहब बोल रहे हैं कि मेरी आवाज कट रही है. ऐसा होना तो नहीं चाहिए. नाउ चेक. अभी तो नहीं आवाज कट रही जी. आई हैव चेंज्ड इट. आई हैव चेंज्ड द माउस, द माइक. नाउ what you see over here, this is Jefferson fracture. So Jefferson fracture is C1 burst fracture. Right? C1 burst fracture. Now where do you get to see this? How do you get to see this? You get to see this in open mouth odontoid view, open mouth odontoid view. Okay, G. Right, open mouth odontoid view. Right, now what you notice over here, so if you notice here, this is the open mouth odontoid view, and this is C1 vertebra which is fractured, and this is C2 vertebra. What part of C2 vertebra? This is called as dens, DENS, dens of C2 vertebra. इसको भी देख लेते हैं. Same fracture, different X-ray. Now this, what I have done is I have outlined the C2 vertebra. I have outlined the C2 vertebra for you. So this is dens, D for dens, and this is the fractured part of C1. ये जो मैंने शेड किया इसको, ये वाला, ये क्या है? This is the fractured part of C1, fractured part of C1. Jefferson fracture. देखो जी ऐसे. Fine. This is dens of C2 and this is C1. Fine. So C1 is broken into many fragments, like this. Broken into many fragments. Right. Now, ये इसको हिंदी में हम लोग रामपुरिया चाकू बोलते हैं. Right. Like this. Foldable चाकू. Okay. Rampuriya chaku, foldable chaku, but in English this kind of knife is called as jackknife. Right. Now if someone is wearing a seat belt, fine, seat belt के कारण उसकी जान तो बच गई, but what will happen? The spine will go into abrupt flexion. Right. Abrupt flexion के कारण क्या होगा? Like this. Because of abrupt flexion, anterior part of vertebra will crush against each other. Fine. And posterior part will be pulled. Apart. खिंच गए एक दूसरे से दूर. Fine. And anterior part will be crushed. So that is why this is called as jackknife fracture. पिछले साल एग्जाम में आया था ये वाला. Fine. Now this is also called as chance fracture. Right. See, anterior injured, middle injured, posterior injured. So as you know, this happens to be a very unstable injury. Right. Jackknife fracture. अब osmosis उनसे उठाया गया क्या? What is this? This is jackknife position. देखो एकदम चाकू जैसी लगती है पोजीशन. Jackknife position. Orthopaedics, रेडियो, किसी से कुछ लेना देना नहीं इसका. This is about the surgery. Jackknife position. किसके लिए? This is a position which is used for spinal surgeries. This is the position which is used for rectal surgeries. Jackknife position. Fine. Now what is this fracture? So you see here C6. Fine. C6 and sometimes C7 is also fractured. So this is clay shoveler fracture, and once again the mechanism is abrupt flexion. Now if it occurs in a live patient, अगर आपका मरीज जिंदा है, then this fracture is called as clay shoveler fracture. If it occurs in dead patient, मरे हुए patient में, in that case what is this called as? This is called as undertaker fracture. Fine. अंडरटेकर मैंने क्लास में भी बताया था, वो लोग हैं जो डेड बॉडी को जमीन के अंदर लेके जाते हैं, अंडरटेकर्स. राइट. नाउ ओके, सो व्हाट यू गेट टू सी, इफ देयर इज अ big fracture of tibia, this is going to be B for bumper fracture, bumper fracture. Then they ask you the mechanism. You see the feet is going outward. So what is the mechanism? Mechanism is valgus force, valgus force, valgus force. नहीं प्रतीक जी, ये इसका वो WWF वाले अंडरटेकर से कुछ लेना देना नहीं है. एक समझ नहीं आई, जब हम लोग देखे थे छोटे होते थे उस समय इसको WWF बुलाते थे, आजकल इसको WWE बुलाते हैं. समझ नहीं आया कुछ क्या कहानी है. आपको समझ आए तो बताइएगा. सो valgus force. So B for big fracture of tibia means bumper fracture, right? See here. So if we go to see a big fracture, this is going to be bumper fracture, right? But if you get to see small fracture of tibia, see here. So if you get to see S for small fracture of tibia, it is going to be S for C-gond fracture. S for C-gond fracture. Oh, okay. Right. Now see here. So you see, it is a type of avulsion fracture. Avulsion मतलब छिल जाना. It is a type of avulsion fracture and it is associated with ligament injury. It is associated with ligament injury. World Wrestling Entertainment. Okay. Now, Galeazzi fracture here. Galeazzi fracture. So you just need one mnemonic. GFR. Galeazzi fractures radius. Fine. Which part? Distal radius fracture with distal radio-ulnar joint dislocation. Distal radio-ulnar joint dislocation. Fine. And then you see there are multiple mnemonics. Grimus. So Galeazzi radius inferior position. Monteggia ulna superior position. Grimus. जो निमोनिक आपको अच्छा लगे उससे याद कर लीजिए. Monteggia fracture उल्टा है. Fracture of proximal ulna with proximal radio-ulnar joint dislocation. देखो जी, यहां पे आपको क्या नजर आ रही? Dislocation, right? Now, what exactly is this fracture? कोई मुझे बताएगा please? What is the name of this fracture? हाँ जी डॉक्टर साहब लोग जी बताइए मुझे, what is the name of this fracture? I'll give you the choice. Whether it is Colles fracture, Smith fracture, Barton fracture or dorsal Barton fracture. हाँ जी, it is Colles fracture. Now, why this is Colles fracture? Very correct. It is Colles fracture. Why this is Colles fracture? Because you see, I'll show you something here. देखो जी, ये रही fracture line. Why this is Colles fracture? This is Colles fracture because this kind of fracture, it is extra articular fracture. Fine. Why this is Colles fracture? See, extra articular fracture, and then you see the distal fragment has gone posteriorly. Right. Now see here, Colles fracture and Smith fracture. So Colles fracture, what is the mechanism? Foosh, fall on the outstretched hand. Smith fracture, what is the mechanism? Inward turned hand. Now this foosh, if it occurs in young adults, it is going to cause scaphoid fracture. It is going to cause posterior dislocation of shoulder. If it occurs in children, it is going to cause supracondylar fracture of humerus. Fine. And if this occurs in elderly, it is going to cause Colles fracture. It is going to cause Colles fracture. राइट दोनों को फटाफट कंपेयर कर लेते हैं. लेफ्ट साइड पे है आपका कॉलेज, राइट साइड पे है आपका स्मिथ. सो फूश. फाइन. फर्स्ट लेट्स राइट द कॉमन पॉइंट्स. लेट्स राइट व्हाट इज कॉमन बिटवीन बोथ ऑफ देम. सो बोथ ऑफ देम दे अफेक्ट डिस्टल एंड ऑफ रेडियस. Distal end of radius. Both of them are extra articular. Both of them, they occur at metaphysis. Because they occur at metaphysis, there occurs rapid healing. So that is why malunion is common. Malunion is very, very common. Fine. Now the differences. Mechanism, Fuchs. Fine. Smith fracture. Inward turned hands. Inward turned hands. Clinical feature, slip. Supination, lateral angulation, impaction, and posterior displacement. Clinical feature, propaganda, pronation, palmar angulation, ulnar deviation. Right? Treatment, propaganda. Fine. Treatment, propaganda. Right? Treatment, slip. And what do we use here? We use hand shake cast. Hand shake cast. How do you identify hand shake cast? Thumb is free. अंगूठे के ऊपर कवर नहीं होगा. Right? Let's quickly see the Barton fracture. First, let's compare Colles fracture with the dorsal Barton. The only difference between Colles fracture and dorsal Barton is that Colles fracture is extra articular, dorsal Barton is intra articular. ये रही fracture line. ये रही fracture line. Right? Then Smith fracture can be compared with volar Barton. ये रही fracture line. ये रही fracture line. Right? That's how you compare both the fracture. You compare both the fractures. Right? Barton fracture. Okay. Now you see here. Bennett fracture. पहला fracture आप देख रहे हैं Bennett fracture. What is special about this? This is most common fracture. Most common fracture of the base of thumb. Most common fracture of the base of thumb. And what kind of fracture is this? This is a displaced fracture. Displaced fracture. How the displacement occurs? देखो ये रही. Bone is broken into two pieces. Fine. And then which muscle pulls? Abductor pollicis longus. Abductor pollicis longus. नहीं समझ में आया? इसमें देखिए. Fine. Bone is broken and abductor pollicis longus. It breaks the bone into two fragments. It breaks the bone into two fragments. And then Rolando fracture. Rolando fracture. Minimum three fragments. So Rolando fracture, minimum 3 fragments. And when a fracture has minimum 3 fragments, what is this called? This is called as comminuted fracture. Comminuted fracture. Rolando fracture. Rolando fracture. Right? Shepherd fracture, it affects the talus. बस इसकी पहचान होनी चाहिए. Very rare. Very rarely they will ask you this. बहुत रेयर पूछेंगे. अगर पूछा भी तो काफी कम चांस है पूछने के. राइट? आगे चलते हैं जी. मैलेट फिंगर वर्सेस जर्सी फिंगर. सो मैलेट फिंगर, रप्चर ऑफ एक्सटेंसर टेंडन. जर्सी फिंगर, रप्चर ऑफ फ्लेक्सर टेंडन। मैलेट फिंगर का दूसरा नाम क्या है जी? बेसबॉल फिंगर। जर्सी फिंगर का दूसरा नाम क्या है? रग्बी फिंगर, रग्बी फिंगर। ट्रीटमेंट दोनों में क्या है? सर्जरी। दोनों में क्या है? सर्जरी। व्हाट इज द नेम ऑफ द स्प्लिंट? यहां पे आप कौन सी स्प्लिंट यूज करेंगे? यू विल बी यूजिंग स्टैक्स स्प्लिंट। यहां पे आप कौन सी स्प्लिंट यूज करेंगे? यू विल बी यूजिंग फ्रॉग स्प्लिंट, फ्रॉग स्प्लिंट, राइट? नाउ व्हाट इज द क्लिनिकल फीचर? देयर इज नो एक्सटेंशन। व्हाट इज द क्लिनिकल फीचर? देयर इज नो flexion. Fine. So this is the injured finger. Injured finger. This is the injured finger. Right? डॉक्टर साहब जी, डॉक्टर अखंड प्रताप जी, देखो जी, डॉक्टर अखंड प्रताप साहब को एक डाउट है। मेरी आपसे रिक्वेस्ट है हाथ जोड़ के, मैं मालूम है मुझे कि आपका समय बड़ा कीमती है, बट 2 मिनट दे दो मेरे को प्लीज। राइट? डॉक्टर अखंड प्रताप जी की क्वेरी को आंसर करते हैं फटाफट से। डॉक्टर साहब जी, ये देखो, ये दिस इज, यू नो, लेट मी जस्ट स्पेंड जस्ट 1 मिनट ऑन दिस। इससे ज्यादा समय नहीं लगाएंगे, प्रॉमिस। राइट? स्वैन नेक और मैलेट फिंगर मैं बताता हूं। राइट? देखो जी, व्हाट यू गेट टू सी हियर, दिस इज एंटीरियर वेंट्रल वोलर फ्लेक्सर। This aspect, anterior ventral volar flexor, ulta, fine. This is dorsal extensor posterior, anterior ventral volar flexor, dorsal extensor posterior, neutral position. This is flexion, palmar flexion. Flexion also called as palmar flexion. Neutral position. Extension also called as dorsiflexion. Extension also called as dorsiflexion. Right? Okay. Now, what happens in, इधर आता हूं, what happens in Colles fracture? आपके मरीज का हाथ ऐसे, what is this? Dorsiflexion. What happens in Smith fracture? Like this. Fine? Palmar flexion. Palmar flexion. तो अगर आपके मरीज का हाथ ऐसे है, दिस विल बी कॉलेज फ्रैक्चर। अगर आपके मरीज का हाथ ऐसे है, फाइन, दिस विल बी स्मिथ फ्रैक्चर। दिस विल बी स्मिथ फ्रैक्चर। राइट? अच्छा, दूसरे हमारे भाई साहब ने पूछा है स्वैन नेक और मैलेट फिंगर। देखो जी, मान लीजिए मैं हूं आपका मरीज। राइट? अब देखिए, ये उंगली मान लो मेरी परमानेंटली ऐसे है, परमानेंटली ऐसे है। आप जो मर्जी कोशिश कर लो, ये सीधी नहीं हो रही, ये स्वैन नेक। राइट? मैलेट फिंगर में क्या होगा? ये आपका हाथ है, मेरी उंगली टेढ़ी। राइट? आप आए, आपने उंगली से अपनी ऐसे किया, लो जी उंगली सीधी, देख लो आपकी हाथ से उंगली सीधी हो गई। लेकिन जैसे ही अपने हाथ हटाया, उंगली फिर टेढ़ी। ये आपका हाथ आया, उंगली सीधी, छोड़ा, फिर टेढ़ी, ये मैलेट फिंगर। लेकिन ये आपका हाथ है, आया, आपने खींच के सीधा करने की कोशिश की, जोर लग गया पर सीधी नहीं हुई, दिस विल बी स्वैन नेक। सो स्वैन नेक इज अ फिक्स्ड डिफॉर्मिटी। राइट? फोटो में नहीं डिफरेंशिएट हो पाएगा। या दे विल, या डॉक्टर वर्ल्ड फैक्ट्स आपकी बात भी सही है, दे विल गिव। ओके, सो दिस इज बॉक्सर फ्रैक्चर। दिस इज बॉक्सर फ्रैक्चर, ये रहा। फाइन? 5th मेटाकार्पल नेक, और इसका ट्रीटमेंट क्या है? अल्नर गटर स्प्लिंट, अल्नर गटर स्प्लिंट, या आप क्या लगाएंगे? के वायर। व्हाट इज दैट? कर्शनर वायर, कर्शनर वायर। राइट? अच्छा, मैं पिछली 2-3 बार से ये बोल रहा हूं कि क्लासिफिकेशन दे आर कॉमनली आस्किंग. Many of you must be knowing that I am at Government Medical College doing a short duration diploma in radio diagnosis. 2024 से मुझे मिला था और उसमें ये वाला क्वेश्चन आया था एग्जैक्टली. Gartland classification. So Gartland classification, it deals with supracondylar fracture of humerus. Supracondylar fracture of humerus. Why this is important? This is most common fracture around elbow. Most common fracture around elbow in the children. Most common fracture around elbow in children. Right? Now see, first, this is non-displaced fracture. Right? What do you get to see? अगर ये फ्रैक्चर दिख ही नहीं रहा एक्सरे में तो आपको पता कैसे लगेगा? कैन एनी वन ऑफ यू प्लीज टेल मी, इफ इट इज अ नॉन डिस्प्लेस्ड फ्रैक्चर, हाउ विल यू गेट टू सी दिस ऑन एक्सरे? आप एक्सपीरियंस है तो आपको पता लग जाएगा, बट हाउ? Fracture line is not visible, but even then you will get to see. What will you get to see? You will get to see fat pad sign. Fat pad sign. You'll get to see sail sign. Sail sign. Right? Now type 1. It is an incomplete fracture. It is an incomplete fracture and it is similar to green stick fracture. Green stick fracture. Right? Yes, very good, Dr. Hemanji. Right? Now here, if it is completely displaced, क्या नजर आएगा आपको? You will get to see fish tail sign. You will get to see fish tail sign. Fish tail sign. Okay? Now, Salter-Harris facial classification system. Salter-Harris facial classification system. Right? Now see, this is about the fracture of growth plate. Fracture of growth plate. Fine. Now here, you see type 1 fracture. So when we talk about type 1 fracture, that is similar to slipped capital femoral epiphysis. Why slipped capital femoral epiphysis is important? Because this is most common hip disorder. This is most common hip disorder in adolescent. Hip disorder in adolescent. What do you get to see? You get to see Prathovan sign. Prathovan sign. What is Prathovan sign? Deranged clean line. Deranged clean line. So this is important. Please just allow me 1 second, please. Sorry, buddy. Now type 2 is also important, because type 2, what do you get to see? You get to see sail sign. Sail sign. देखो जी, ये रही sail. This is the sail. Fine? Like this. Sail sign. You get to see something called as sail sign. Type 3 is not important. Type 4 again is important because this is similar to lateral condyle of humerus fracture. Lateral condyle of humerus fracture. Right? So Salter-Harris facial classification, very important. Right? Now, what is this? So this is Powell classification. Powell classification. किसकी? neck of femur fracture. Neck of femur fracture. So this is based on angle of fracture line. Angle of fracture line. So this fracture is stable and this fracture is unstable. What does this say? It says more the angle, more is instability. More is instability. Right? Okay, then what is this? So this one is garden fracture. Garden fracture.
कर लो हो गई है.
So it is based on displacement. It is based on displacement. Don't remember the detail, but उसका basis याद रखना है. I'm coming to that. I'm coming to that. Dr. World Fact जी, I'm coming to that. लो जी, आपकी बात टालनी ही नहीं हमने. Extra capsular fracture, right? Now, extra capsular fracture. This occurs with trivial trauma. I think video was stuck, but now I believe it is working. अच्छा ओके जी, ओके 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 ओके, राइट 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 राइट, ओके ओके, ठीक है ठीक है ठीक है, राइट. आगे टाइम कम है. बाय बाय बाय. Again, if your patient is young, fine. Now, let's say, okay, let me repeat it very very quickly. So if your patient is having this fracture, what is the treatment? Dynamic hip screw or intramedullary nail. In young patient, you can do open reduction, internal fixation. In old patient, if your patient has osteoarthritis, total hip replacement. If there is no osteoarthritis, hemiarthroplasty. Hemiarthroplasty. What is the complication here? What is the complication? Complication is malunion. What is the complication here? Complication is non-union. Complication is non-union. Right? Now let's quickly compare the supracondylar fracture with lateral condyle of humerus fracture. This is most common fracture around elbow. Most common fracture around elbow in children. And this one is second most common. This one is second most common here. So most common complication, most common complication here. This would be malunion. Here, this would be non-union. Non-union, right? Treatment in both is surgery. Treatment in both is surgery. Treatment in both patients is surgery. In both patient, the treatment is surgery. The nerve injuries: anterior interosseous nerve, median nerve, radial nerve, ulnar nerve. And here the nerve injury is ulnar nerve. Ulnar nerve. Fine. Now this malunion is cubitus varus deformity. This non-union is going to give rise to cubitus valgus deformity. Cubitus valgus deformity. Fine. आपको इतना सब नहीं याद रखने का मन, कोई बात नहीं. Just remember this: malunion and non-union. Supracondylar fracture. So most common nerve injury is anterior interosseous nerve. यहाँ पे what is the most common artery injured? Anterior interosseous artery. What are the other complication? Volkmann ischemic contracture. Volkmann ischemic contracture. How do you treat Volkmann ischemic contracture? With the help of turnbuckle splint. Turnbuckle splint, right? अच्छा, splint का जिक्र आ रहा. Let us quickly see some of the splint. फटाफट से कुछ splint को देख लेते हैं, उसके बाद थोड़े से क्वेश्चन, right? Now see here. So if you see threads मतलब रफ चूड़ी जिसको बोलते हैं हिंदी पंजाबी में. फाइन. सो व्हाट एग्जैक्टली इज दिस? सो दिस वुड बी ऑस्टिन मूर pin. Fine. Now here, this is hip prosthesis. If you see two holes here, so again, what is the name? Austin Moore prosthesis. Austin Moore prosthesis, right? Austin Moore prosthesis. Okay, right. Now, if there are no holes, if there are absolutely no holes, what is the name? In that case, the name will be Thompson prosthesis. Thompson prosthesis. Now, if you see a thin wire, what is the name? Kirshner wire. दूसरा नाम क्या हुआ जी? K wire. K wire. If you see a smooth pin, S for smooth, S for Steinman pin, लंबी सी pin, मोटी सी Steinman pin, right? Then Denham pin. How do you identify Denham pin? In the middle there will be threads. In the middle there will be threads. Fine. K wire, Kirshner wire. Okay. Can any one of you tell me any one use of K wire? Displaced fracture of patella. Fine. What do? We do tension band wiring. Tension band wiring. Right. Now, what are these? So these are crutch field tongs. Crutch field tongs. Fine. Very good. Very good. Now, as you can see, ये पहले बता ही दिया था मैंने. What is this? Thompson prosthesis. And what is this? Bipolar prosthesis. Bipolar prosthesis. Bipolar prosthesis. Fine. Now, this is Gallo traction. How do you identify? Hips don't touch the bed. Hips don't touch the bed. Fine. Now this one is Bryant traction. Bryant traction. Bryant traction. Right. Okay. This one is Hamilton Russell. आपका मरीज सीधा लेटा हुआ और पुल्ली छत के साथ बंधी हुई. Hamilton Russell traction. फाइन. एक टांग सीधी, एक टांग मुड़ी हुई. 90 traction. 90 traction. Right. 90 traction. And this one is buck traction, where you get to see a crossbar. That is buck traction. Fine. And here you see there is no crossbar. There is no crossbar. That is Bryant traction. So if there is a crossbar, that is buck traction. And if there is no crossbar, that is a Bryant traction. Right. Now this is Bowler Brown splint. Bowler Brown splint. Right. Now this one is Kramer wire. Kramer wire. Right. Used for making splint. Now ulnar gutter splint. Ulnar gutter splint. Right. Now tri-point splint. Tri-point splint, it is used for swan neck. It is also used for botonier. It is also used for botonier deformity. Botonier deformity. ये क्या है? This is Stack's splint. What is this? This is frog splint. If the finger is in flexion, F for flexion, F for frog. Fine. If the finger is straight, S for straight, S for stacks, splint. So tri-point splint, it is used for both swan neck as well as for Bottonoir deformity. Fine. Now what do you get to see? This is knuckle bender splint, used for ulnar nerve, and this one is cock up splint used for radial nerve, right? Thomas splint, right? Hip spica cast, again you have to identify this. Okay, so commonly used between 2 to 5 years. Now what is this? This is buddy strapping. Fine. Now what is this? ये आपको फोटो पहचाननी पड़ेगी. So if you see, it is touching the face. Milwaukee brace. All of them, they are used for scoliosis. What angle do you measure? Cobb angle. Now this one is Boston brace. Now this one is turnbuckle cast. Fine. Turnbuckle cast. If it is just stopping over the chest, fine, then it is Boston. देखो थोड़ा सा गलत तरीका है याद करने का, but bossum means chest. Boston brace, the one which stops at the chest, जो chest पे आके रुक जाए, that is Boston, right? और जो chest के ऊपर चली जाए, that is Milwaukee, right? Turnbuckle cast, don't confuse it with turnbuckle splint. Turnbuckle splint is for Volkmann ischemic contracture. Turnbuckle cast is for scoliosis. Now what do you get to see over here? This one is giggly saw, bone को काटने के लिए. Fine. This one is osteotome. Fine, bone में छेद करने के लिए. Yes. Bob. World fact I got. How smart you are. Periosteal elevator. Right. Now this one is bone nibbler. Yes. Now this one is bone cutter. And if you see something curved, fine. So this one is rib cutter. Right? Okay. फटाफट से जरा 2-3 क्वेश्चंस का आंसर दे दो प्लीज. Not this. Yeah, this. Okay. I hope you all can read this. Very quickly, please read and let's answer. ये वाला टाइम हम लोग नहीं गिनेंगे. I'll extend the class, but please answer. So, motor vehicle accident, shortened, adducted and internally rotated. Motor vehicle collision, severe pain, unable to move the limb. Femoral head lies superior and posterior to acetabulum, with disruption of posterior acetabular rim. Now, very good, Bhaiji, sciatic nerve. So as you can see, this patient is suffering from posterior dislocation of hip. छा गए भाई, छा गए. Okay. 35-year-old man sustains high-end road traffic accident, collides head-on motorcycle collides head on, abducted, externally rotated and lengthened. Severe pain. First of all, you see here what is the problem? Bike accident, abduction, external rotation. Femoral head is palpable in the region of femoral triangle. Weakness of knee extension. Distal pulses are intact. Femoral head lies anterior. Okay, which of the following structure is most likely injured in this condition? डॉक्टर साहब ये रही options. Right here. This would be the answer. This would be the answer. Right? Thank you. 14-year-old boy presents with persistent pain and swelling over tibia. Okay. MRI shows lytic lesion localized to metaphyseal region extending towards epiphysis but not crossing it. Biopsy confirms osteosarcoma. Which of the following best explain predilection of osteosarcoma for metaphyseal region? Why it is present? Why it is present? Yes. So here, please tell me the answer. Question number 3, whether the answer is A, B, C or D. Question number 3. Simple one-liner question. Why is osteosarcoma common at metaphysis? Why is osteosarcoma common at metaphysis? Simple question. High rate of enchondral ossification. High rate of enchondral ossification. Fine. It has got nothing to do with bone marrow. Remember, bone marrow. What tumor arises? From bone marrow arises multiple myeloma. Very quickly. Most common primary malignant bone tumor. Multiple myeloma. Most common primary malignant bone tumor of osteogenic origin, osteosarcoma. Second most common, Ewing sarcoma. Third most common, fine, chondrosarcoma. Most common benign bone tumor, osteochondroma. Most common benign true bone tumor, osteoid osteoma. Osteoid osteoma, right here. So this has got nothing to do with bone marrow. 45-year-old man sustained mid-shaft humerus fracture 5 months ago, treated with functional brace. He now presents with inability to extend his wrist and fingers. So that means it is a fixed deformity. Persistent pain, abnormal movement at the fracture site. Radiographs show a persistent fracture gap with sclerotic ends and absence of bridging callus. Electromyography confirmed denervation of wrist extensor muscle. Which of the following best describes? Yes, you see, sclerotic ends. Fine, sclerotic ends. So this is hypertrophic non-union. Hypertrophic non-union. No, sorry. Let's see. Sorry. So it has got to be atrophic non-union with associated radial nerve injury. Associated radial nerve injury. Atrophic non-union. Atrophic non-union. Right? Atrophic non-union. Right? Okay. 7-year-old boy presents with painless limp for 3 months. That's why I've changed the answer. His mother reports intermittent hip and knee pain that worsens after activity. Limitation of hip abduction and internal rotation. No history of trauma. Frog leg radiograph of the pelvis reveal increased density and flattening of femoral head with widening of joint space. Acetabulum is normal. First of all, what is the age? 7 years. 7 years. So 7 years plus a question on hip. Always considered Perthes disease. Always considered Perthes disease. So first option, he is talking about slipped capital femoral epiphysis, common in the age 11 to 14 years. 11 to 14 years. Inflammatory destruction, no. Fine. This is also not the right answer. So B, ischemic. So what is your patient talking about? Perthes disease. Now Perthes disease, what is important? Please open your notes and do watch the image of bite sign and crescent sign. Very, very important. Both are bite sign and crescent sign. 13-year overweight boy presents with progressive pain, groin and knee for 2 months, accompanied by limp, no history of trauma, restriction of internal rotation. See the age. X-ray of the pelvis shows posterior inferior displacement of femoral head with widening of physis. Which one of the following explains anatomical basis and pathophysiology? Yes. Anyone? So this slipped capital femoral epiphysis. Slipped capital femoral epiphysis. Shear means horizontal stress. Horizontal stress. Horizontal stress. Okay, horizontal stress. You see, there is no abscess. There is no abscess. So, question on the hip. Age of the patient between 11 to 14 years. Please believe me, it will always be about slipped capital femoral epiphysis और कुछ भी नहीं पूछेंगे. Right? Okay. 9-year-old boy falls on the outstretched hands, sustains injury to right elbow, limb is swollen, child hold his elbow in severe pain, radial pulse is found to be feeble, forearm is pale, capillary refill is sluggish, passive finger extension produces pain. Radiographs, they reveal supracondylar fracture. Which one of the following event explains vascular and neurological find? Direct laceration नहीं होती. Brachial artery is a strong, thick artery. कटेगी नहीं. Entrapment of brachial artery, no. Compression of brachial artery, this is the right answer. This is the right answer. Fine. So brachial artery is swollen by the pressure. Swollen by the pressure. Brachial artery is not directly injured. Brachial artery सीधा सीधा injure नहीं होती. Supracondylar fracture. Yes. थोड़ा स्लो पढ़ते हैं इसको. 82-year-old, osteoporosis, trivial trauma, pain in the left groin, inability to bear weight, left leg is shortened and externally rotated. X-ray pelvis reveals transcervical fracture of femur, with the femoral head remaining in normal position. 2 weeks after fixation, patient develops persistent groin pain and follow-up imaging shows increased density. When you see increased density, please do suspect avascular necrosis. Avascular necrosis. Which of the following best explains pathophysiological mechanism? Please read. Now, if I have to ask you in one-liner, as a one-liner question, I will ask, what is most common vessel affected in neck of femur fracture? If I have to ask you this question in one-liner form, अगर मैंने आपको ये one-liner form में question पूछना हुआ, तो मैं ये पूछूंगा, which artery or vein is commonly affected in neck of femur fracture? बताइए. वाह मेरे शेर डॉक्टर अहमद खुर्शीद जी, you got the right answer. Medial circumflex femoral artery. Medial circumflex femoral artery is commonly affected. Right? Okay. Because थोड़ा सा 2-4 मिनट हमने लेट शुरू किया था. Let us quickly read about psoriatic arthritis. Psoriatic arthritis, it is called as seronegative arthritis because RA factor is always negative. Male female ratio is equal. Age group 30 to 50 years. 30 to 50 years. What is the causative agent? HLA B27. HLA B27. Most common pattern is asymmetrical oligoarthritis. Fine. Now here, what kind of clinical features? Sausage fingers. Osteolysis, it gives rise to telescoping of the digits. You pull, this finger will become long. Release, this finger will become short. Now, can anyone tell me what is this? So this is called as opera glass hands. Opera glass hands. Fine. You see why they are called opera glass. हो गया, नहीं हुआ. चला जी. आया तो है बट हुआ नहीं. हाँ चल गया. ओके, थैंक यू. Talks of these are the circumstances beyond our control as of now. Really sorry, but कोई नहीं. I'll repeat. Don't worry. This is like opera glass hand. Okay. Now, what do we get to see on the X-ray? We get to see something called as pencil in the cup appearance. I'm really sorry for the gap face, but these circumstances are beyond our control. You see, this is pencil. What do you get to see? Pencil in the cup appearance. Right? Now, you also get to see bright white phalanx. Now, this is called as ivory phalanx. This occurs due to healing. Right? Now, treatment is you give NSAIDs, retinoids, cyclosporin, and etanercept and infliximab. That was about psoriatic arthritis. ये थोड़ा important है, इसलिए मैं इस पे focus कर रहा हूँ जी. Rheumatoid arthritis. It is common in females, especially middle age. So most common age, this would be 20 to 50. Now it is associated with herpes simplex virus, Epstein-Barr virus. It is associated with smoking. HLA, DR1, DRW4. Cytokines, interleukin 6 and 1. Most common joint, metacarpophalangeal joint. Fine. Clinical features, symmetrical polyarthritis, early morning pain. right? Now the deformities. So your patient who is suffering from rheumatoid arthritis will develop mallet finger, but this mallet finger would be fixed. Okay, then what exactly is this? So you see here, so there is extension at PIP and flexion at DIP, flexion at DIP. So this is swan neck, and if it is reversed, flexion at PIP and extension at DIP, so this would be botonier deformity. Fine, already written. Now this is Z deformity. Now if you see that the ulna has moved, dislocation of ulna, now this is called as piano key sign. R effector. What is the problem with R effector? R effector is non-specific. Specific is anti-CCP, cyclic citrullinated peptide. Treatment is NSAID and DMARD. What are the association? Felty syndrome, Sjogren syndrome, right? You see, Felty syndrome is written, associated. Sjogren syndrome is written, associated. Fine. Carpal tunnel syndrome is written. So these are the syndromes which are commonly associated with rheumatoid arthritis. Now these are the two mnemonics for disease modifying anti-rheumatoid drugs. Drug of choice is methotrexate. Very little time, no problem. Now ankylosing spondylitis, it is associated with HLA B27. Primary site of inflammation is anthesis. It will affect male 15 to 25 years of age. Axial skeleton, so it starts at sacroiliac joint. Fine. Then there are many extra articular manifestation like iridocyclitis, IgA nephropathy, inflammatory bowel disease, right? Clinical tests: lumbar spine, Scober test, sacroiliac joint, Faber test, figure of 4 test, right? Radiological sign: haziness and widening around sacroiliac joint. Fusion of all vertebra, bamboo spine, white line in the middle, dagger sign. White line on the side, railroad sign. White line on the side, white line in the middle, trolley track sign, right? Treatment: NSAIDs and infliximab, right? Okay, now some of the questions in radiology, some of the questions in radiodiagnosis. Fine. Now radiodiagnosis have deliberately kept one-liner question because they are covered with the other subject. Now please keep on answering the questions. All the silly questions I've already erased. Fine. So please keep on answering. Let's stay active. What is the best imaging first imaging for suspected stroke within 1 hour of onset? within 1 hour of onset? ए नहीं आंसर देना भाई, देखो फर्स्ट इमेजिंग यहीं पे गलती करते हैं हम लोग. सो फर्स्ट इमेजिंग इज नॉन कंट्रास्ट सीटी. इट इज डन टू रूल आउट hemorrhagic stroke. It is done to rule out hemorrhagic stroke. First imaging is non-contrast CT. Just give me a minute. Non-contrast CT. So it is done to rule out hemorrhagic stroke. So answer is B. Non-contrast CT. Yes, this MRI, it is confirmatory. Diffusion weighted image. It is confirmatory. Once you have ruled out the hemorrhagic stroke, now you will perform MRI DWI, and must keep in mind that on diffusion weighted imaging, the infarct area should appear white, right? And on ADC images, fine, this area should appear black. So these are the findings of infarct. What territory is affected? Which artery is affected? So this is the territory of middle cerebral artery. This is the territory of middle cerebral artery. Very good. Middle cerebral artery. So this is the territory of anterior. This would be the territory of posterior, right? Best X-ray view for suspected scaphoid fracture with normal PA view and lateral view. With normal PA view and lateral view. Yes, anyone? So this is B. PA view with ulnar deviation. Investigation of choice in a scaphoid fracture is MRI. In a scaphoid fracture, the investigation of choice is MRI. See, scaphoid fracture. What are the common complications here? Non-union and avascular necrosis. Avascular necrosis. Right? Okay, I'll keep this here. Right. So, if your patient is suffering from pulmonary embolism in a non-pregnant patient, what is the investigation of choice? What is the investigation of choice in a non-pregnant adult? What is the investigation of choice if you are suspecting pulmonary embolism? So it will be CT pulmonary angiography. Right? So this is a CT pulmonary angiography. Okay. Now here, ultrasound sign of acute cholecystitis. Anyone? And then you'll have to give me the answer to the other questions also. Ultrasound sign of acute cholecystitis. Murphy sign sonographic. Fine. So what is Murphy sign? Murphy sign is inspiratory arrest on probe pressure. Inspiratory arrest on the probe pressure. Now where do you get to see starry sky liver? Starry sky liver, where do you get to see? Starry sky liver, where do you get to see? So starry sky liver you get to see in viral hepatitis. You get to see in viral hepatitis, starry sky liver. Now these two sign, target sign, T for target, T for transverse view, transverse view. Pseudo kidney sign we get to see in longitudinal view. What investigation? Ultrasound. And where do you get to see? Intussusception, intussusception, right? You get to see in intussusception. So these are the findings which you notice if your patient is suffering from acute cholecystitis. If your patient is suffering from acute cholecystitis, first, wall thickening, gallbladder wall thickening. How much? More than 4 mm. Gallbladder wall thickening. How much? More than 4 mm. Right? Then you will get to see pericholecystic fluid. Pericholecystic fluid. So around the gallbladder you will get to see pericholecystic fluid. Right? Then you will get to see this PAS, posterior acoustic shadowing. Posterior acoustic shadowing from the stone. Posterior acoustic shadowing from the stone. Right? See, what you get to see over here? So you get to see increased wall thickness. Increased wall thickness. And what do you get to see over here? So this is calculi, gallbladder calculi, and this one is PAS, posterior acoustic shadowing. Posterior acoustic shadowing. Right? Now, so this, what do you get to see? This one is target sign seen on intussusception. This one is pseudo kidney sign. Pseudo kidney sign. Fine. Now, here, this one is real kidney. This one is real kidney on ultrasound. Real kidney on ultrasound. So what do you get to see over here? This is cortex of the kidney and this is medulla of the kidney. Please tell me which structure is appearing hyperechoic. Laddu question, very simple question. Which structure is appearing hyperechoic? I just want to see whether you can differentiate the findings on of ultrasound or not. Which structure is appearing hyperechoic? Please don't mind that I'm asking you super easy Laddu type of questions. But yes, tell me. Right? I asked hyperechoic. Hyperechoic. Hyper. So anything which is hyper will be appearing brighter, white. So cortex, as you can see here, is hypoechoic and medulla is hyperechoic. Medulla is hyperechoic. Fine? Hyperechoic. See here. So this is liver, right? And this is right kidney. Fine? This is spleen on the left side and this is left kidney. Fine? Between liver and right kidney there is a space. Hepatorenal pouch. Can any one of you please tell me what is the significance in radiology? What is the significance of hepatorenal pouch? So when we do fast, focused assessment with sonography in trauma, we look at 4 P's. Fine? Perihepatic. So hepatorenal pouch is most dependent most dependent intra-abdominal part. This is where we find the fluid. Perisplenic, pelvis, pericardial, right? Okay, most radiosensitive cell type in the given option, most radiosensitive cell type. So here, this would be lymphocyte. Why? Because you see these cells, they have high turnover, most radio-resistant. This is also radio-resistant. This is also radio-resistant. Chondrocyte are radio-resistant. No turnover. देखो जी ये radiosensitivity and the cell type. So you see, germinal cells are sensitive. Seminiferous tubules are sensitive. You see buddies here, आपको जरा सिर्फ अगर 1 मिनट मुझे जरा समय दीजिए. आई जस्ट वॉन्ट टू एड वन इमेज, उससे आपको पता लग जाएगा व्हाट आई एम ट्राइंग टू स्पीक अबाउट. वेट, ऐसे वाला आंसर नहीं देना है आपको कभी भी यार. Just allow me 1 minute. Yeah, this. I'll take this picture and I'll share with you. Now, see here. Just a minute, I'm adding a picture. See. Now, when you are protecting your radiographer from the harmful effect of radiation, you are trying to protect the gonads. You are trying to protect the gonads. So these are the devices which you give to the radiology department staff. Devices which you give to the radiology department staff. Right? So you are trying to protect the gonads. So that means gonads are supposed to be sensitive. Gonads are supposed to be sensitive to the effects of radiation, right? And I'm sure from wherever you have studied radiology, you must have studied about these things. Radiosensitive tumors and radio-resistant tumor, radiosensitive. Ewing sarcoma, when radiotherapy is given, it simply melts away. Renal cell carcinoma, the only effective treatment is surgery. इतना तो सर्जरी में आपने पढ़ा है. Dr. Garima ji, but 16 centimeter, if your patient is asymptomatic, right, then it does not require surgery. But yes, what you should be aware is, I'll give you a table here. In new Lavan Bailey, they have clearly given that which gallbladder stones must be operated. Which gallbladder stones must be operated, right? I'm very happy when you guys ask me your queries, right? Just give me a minute and I'll add this thing over here. Yes, this is a favorite question of the examiner, that which stones should be removed. Which stones should be removed and which stones should not be removed. Fine. But first, let us finish this topic, right? See here. So these are radio-sensitive tumor. These are radio-resistant tumor. You don't want to remember all these? Perfectly okay. Just remember Ewing is radio-sensitive. Just remember Wilms is radio-sensitive. And just remember, renal cell carcinoma and hepatocellular carcinoma are radio resistant. Now, why the rest are not important? Because you know that this is most common radiation induced tumor. If it is forming out of radiation, how will radiation destroy it? जो बना ही radiation से है, radiation कैसे तोड़ देगी उसको, right? So this is the list. Okay, now radiosensitive cells and radio resistant cells. इसमें भी आप बोलते हो कि सर और बड़े सब्जेक्ट हैं पढ़ने को, आपका कहां से पढ़ते रहे? Just remember these, right? And just remember these, only these things. If you remember, perfectly okay, right? Okay, now see here. जो डॉक्टर साहब ने हमारे क्वेश्चन पूछा था, कहाँ गए डॉक्टर साहब? डिलीट कर दिया कमेंट उन्होंने? नहीं है डॉक्टर गरिमा जी, this is a table taken directly out of Love and Bailey 28th edition. So if any stone is more than 3 centimeter, there is risk of cancer, must operate it. Choledocholithiasis, your patient will develop jaundice, pain, fever, right? Chronic hemolytic condition, remove it, fine. Polyp more than 1 centimeter, fine. Risk of cancer, remove it, right? Now comes your answer, Dr. Garima ji. If your patient is living in North India and he or she has a gallbladder stone, it is always better to get it removed, because our area has very high prevalence of gallbladder cancer, more than 60-year-old in females, right? So Northern India, if your patient is in North India and has got a gallbladder stone, advise cholecystectomy, right? Okay, now see here, deterministic versus stochastic example. What you have to do is you have to pick the correct one. Which one do you think is correct? Leukemia is deterministic. This is wrong. Leukemia is stochastic. Can happen. See, first let's understand the difference. So if we say stochastic effect can happen, D for deterministic definitely happens. Can happen, definitely happens, fine. So D, again there is another D, so this is dose dependent, fine. D definite, D determinist, D dose dependent, right? Dose dependent. Stochastic, for example, stochastic and deterministic. Okay, now try to understand with the very bad example. If somebody smokes a cigarette for the first time, he will cough. That is for sure deterministic. If somebody keeps on smoking cigarette for 20, 30, 40 years, you will say you can probably develop cancer. Probably. लोग ऐसे हैं 50-50 साल 40-40 डब्बी रोज 40-40 सिगरेट रोज की पी जाते हैं, कैंसर नहीं होता. So stochastic means can happen. Deterministic definitely happens. Fine. You see here. So this. Now please tell me which curve is deterministic, A or B? Which curve is deterministic? Which curve is deterministic? So this is deterministic, this is stochastic. Deterministic and stochastic. right? Deterministic and stochastic. Okay. Now, again, then there is a concept of radiation dose. Fine. So, RAD, radiation absorbed dose. Radiation absorbed dose. Just energy deposited per unit mass. Fine. What is the unit? Unit is gray. Then radiation equivalent dose. Radiation equivalent dose. So this is dependent upon radiation type. Radiation type. Okay. Just imagine, I'm sitting in front of this heater, and this heater is releasing infrared rays. Any harmful effect to my body? No. But imagine I'm sitting in front of X-ray machine. My body is being hit with X-rays. There will be damage? Yes, there will be damage. So type of radiation are important. Then, no, this time it is not me. Suppose your patient, radiation hits the shoulder joint. Any damage? No. Radiation hits the gonads. Any damage? Yes. So when you are checking the damage to the tissue, that is called as effective dose. That is called as effective dose. Effective dose. Right? So here, what do you think is the answer? Leukemia is deterministic? No. Skin erythema is stochastic? No. After fixed radiation dose, erythema would occur. Cataract is deterministic. If you give too much radiation, cataract would occur. Genetic mutation is stochastic. Okay, safest gadolinium agent in end stage renal disease. End stage renal disease. Remember, your patient can suffer from NSF, nephrogenic systemic fibrosis. So it develops after several years. Your patient develops something called as woody skin. Right? Now, which agent is safe if your patient has kidney failure? Gadoterate meglumine. That is safe in kidney disease. CT sign of acute subarachnoid hematoma. CT sign of acute subarachnoid hematoma. Yes, please tell me. And then I'll ask you the follow-up question. So, hyperdense sulci and basal cistern. Later, if your patient has enough bleed, then your patient will develop star of death appearance. Dense MCS sign. It is seen in acute stroke. Loss of gray-white differentiation you get to see in chronic infarct. Pneumocephalus. What is the name of the sign which you get to see? Mount Fuji sign. CT sign of acute subarachnoid hematoma. Right? Okay. Now, please tell me, what do you get to see here? What is the name of this sign? What do you get to see on your screen? What is the name of this sign? The one which you get to see on your screen. जो आपको स्क्रीन पे नजर आ रहा जी, इसका जरा नाम बता दो. Please tell me. ऐसे मत बोलो please. What is the name of this sign? This is ischemic stroke, but what is the name of this sign? This sign is called as dense MCA sign. Dense middle cerebral artery sign. Dense middle cerebral artery sign. Fine. Now this is what we call at loss of gray and white matter differentiation. Loss of gray and white matter differentiation. Fine. Now this is about TLD badge. TLD badge. What is TLD badge? एकदम से वो सामने आ गया तो मुझे लगा ये भी क्वेश्चन पूछ लेते हैं. What is TLD badge? Fine. Now please tell me, where do you wear TLD badge? Where do you wear TLD badge? Oh, TLD badge, where do you wear? Below the apron or above the apron? It's already clearly written. It is worn below the lead apron. It is worn below the lead apron. TLD badge, it is worn below the lead apron. Below the lead apron. That's a common question which they ask. Where do you wear the TLD badge? Thermoluminescent dosimetry. Thermoluminescent dosimetry badge. So it is worn below the lead apron. Below the lead apron. Best chest x-ray for small pneumothorax. Best chest x-ray view for small pneumothorax. Tell me. Yes, please tell me. Best chest x-ray view for small pneumothorax. So answer is expiratory PA view. Expiratory view, PA view. Lordotic view, it is used for epicogram, that is to see the lung episis. Lung episis. Right? Lung episis. Okay. Now, lateral decubitus, affected side down. It is used for pleural effusion. Right? Now see here. This is full inspiratory film. So 10 ribs. And expiratory less than 8 ribs. Less than 8 ribs. Fine. Expiratory films. Inspiratory about 10 film, 10 ribs posteriorly. And expiratory 8 or less than 8 ribs are seen posteriorly. Fine. First line imaging for suspected renal colic. First line imaging for suspected renal colic is non-contrast CT. Is non-contrast CT. Non-contrast CT. Fine. Now, if you want to see uric acid stones, if you want to see uric acid stone, which investigation you will prefer? Which investigation you will prefer? For uric acid stone, which investigation is preferred? For uric acid stone, which investigation? Dual energy CT scan. Dual energy CT scan. Uric acid stone are best visualized by C. So this is non-contrast CT scan showing the stone. non-contrast CT scan showing the stone. Okay, what do you get to see over here? What do you get to see over here? Superior pole, middle pole, lower pole. Superior pole, middle pole, lower pole. Now, Dr. Prajwalji, contrast CT ne dual energy CT. For uric acid stone, dual energy CT. Fine. So this is horseshoe kidney. Horseshoe kidney. Right? Horseshoe kidney. Now, let's say if superior pole, middle pole, lower pole both are fused, then what will that kidney be called? That kidney will be called as pancake kidney. Pancake kidney. If only fusion at the lower pole, that is called as horseshoe kidney. That is called as horseshoe kidney. Now please tell me, dear doctors, is this renal stone or is this IVP? Is this renal stone or is this IVP? Intravenous pylography, intravenous urography. Please tell me, is this renal stone or is this IVU, intravenous urography? Tell me. What do you get to see on your screen? Is this a renal stone or is this the dye in intravenous urography? If it is IVP, ureter would also have dye. There is no dye in the ureter. No dye in the ureter. No dye on the opposite side. No dye on the opposite side. So this is a stone only. This is a stone only. Okay. Now what stone it could be? Calcium oxalate. Monohydrate or dihydrate? Dihydrate. Right. Brachytherapy. Permanent seed implant in prostate is. So it is low dose radiotherapy and they are placed permanently. They are placed permanently. Right? Permanently. Radiation safety. Best single practical principle. Best single practical principle is ALARA. As low as reasonably achievable. As low as reasonably achievable. Right? ALARA. Contrast nephropathy prevention. Iodinated CT. See, in the test and discussion which I have done earlier, I did discuss clinical questions in radiology, but then I have very little time. I have time, but you guys have very little time because exam is round the corner. That is why I have kept the one-liners. Fine. No time to be wasted in reading the long statements here. Right? Contrast nephropathy prevention. N-acetylcysteine useful but not very useful. Sodium bicarbonate no. Fine. So answer is isotonic saline hydration. It is useful but not very useful. So answer is saline hydration. Saline hydration. Okay. N-acetylcysteine is good but it is not the best. It is not the best. Right? Thyroid ultrasound, malignant feature. Malignant feature. Fine. So spongiform. Spongiform means solid plus liquid. Solid and that too low density solid. Taller than wide. Fine. So कैंसर is standing tall in front of you. हाँ भाई सर्जन क्या कर लेगा? आजा जरा मैदान में. Right? So this is malignant feature. This is malignant feature. Purely cystic, benign. Peripheral eggshell calcification, benign. Spongiform, benign. So malignant feature is B, taller than wide, taller than wide. Acute epidural hematoma, hallmark, extraaxial. So let's say this is the axis center. If the bleed is away from the center, this will be called as extraaxial bleed, away from the center, away from the center. Pulmonary embolism in pregnancy with normal chest x-ray, preferred imaging. So your patient is now pregnant. That means you don't want to give any radiation, especially during first trimester. Normal chest x-ray. What is the investigation? Ventilation, perfusion, scan. But this is not the question. My question is, what do you get to see on chest x-ray? What does the chest x-ray show if your patient is having? See, D-dimer is a screening test. D-dimer is just a screening test. Fine. D-dimer, डॉक्टर कौन सा है हमारे? डॉक्टर हेमंत जी, डॉक्टर प्रज्वल जी. D-dimer, what is the problem? D-dimer can be positive in DVT also. Patient just has DVT. D-dimer test positive. क्या कर लोगे? Right? You have to confirm. So what does X-ray chest in pulmonary embolism show? It shows Hampton hump. It shows Hampton hump. Right? Hampton hump. आगे है, आएगा, मैं दिखा दूंगा आपको. Hampton hump. मुझे लगा था मैंने फोटो ऐड करी है, मैंने करी है, आगे आएगी कहीं पे. MRI sequence. Acute infarct is best detected by. See, T1 sequence is just for anatomy. Is just for anatomy. T2 sequence is for fluid, for pathology, for tumors. So answer is B. DWI, diffusion weighted images with ADC map, with ADC map. So FLAIR is for pathology, fluid attenuation inversion recovery. So this is for pathologies closer to ventricle, closer to ventricle. Fine. SWE, susceptibility weighted images. SWE sequence. This is for micro bleeds. For example, diffuse axonal injury. Diffuse axonal injury. Radiotherapy, 4 hours. Fractionation. Fractionation means division of dose. Division of dose into several cycle. Division of dose into several cycle. So it does via all of these. Fine. But main mechanism is repair of sublethal damage, so that healthy tissue can recover. Healthy tissue can recover. Can recover. Bowel obstruction. X-ray hallmark. See, I told you now, I've added the picture of Hampton's hump. I've added the picture of Hampton hump. Yes, bowel obstruction X-ray hallmark will be multiple air fluid level. Crescent lucency. Now this is called as cupola sign, and this occurs in perforation. Perforation. Perforation peritonitis. You guys commonly call it air under diaphragm. Bulging fissure sign. Where do you get to see? You get to see this in atelectasis. Hampton's hump, you get to see in pulmonary embolism. Yes, Dr. Kanwar Thakur साहब जी, क्यों नहीं? PDF I will share. आप ही के लिए तो बनाते हैं PDF, क्या करना है हमने रख के, right? So you get to see this is omega sign, fine, also called as bent inner tube sign. If convex part is on the left side, then it is going to be sigmoid valvulus. If convex part is on the right side, then it is going to be cecal valvulus. What is the difference? Sigmoid valvulus 70 to 80 years. Cecal valvulus 50 to 60 years. Here, acute onset, sudden onset. Here, gradual onset. Right? Okay. Now this is the typical step ladder. सीढ़ी, एक करके सीढ़ी चढ़ना, या कॉफी बीन साइन बुलाइए, बेंट इनर ट्यूब बुलाइए, ओमेगा साइन बुलाइए, all are same. Cecal valvulus gives rise to embryo sign. So dear doctors, this is Hampton hump. Seen in pulmonary embolism, and this is bulging fissure sign. You see, bulging fissure sign. So bulging fissure sign here, this is seen in atelectasis. Bulging fissure sign. See here, bulging fissure sign seen in atelectasis, right? Where you get to see in lobar pneumonia, especially Klebsiella pneumonia, right? Okay, contrast nephropathy. Anaphylactoid reaction is the most common adverse effect of contrast media, right? How do you treat it? You treat with epinephrine, IM or IV epinephrine, intramuscular or intravenous epinephrine. Anaphylactoid reaction is the most common side effect of contrast media. Right? Best view for pleural effusion on X-ray. First of all, what is the investigation of choice for pleural effusion? Investigation of choice for pleural effusion is ultrasound. It can detect 2 to 5 ml of free fluid. Fine. So lateral decubitus with affected side down. Very good. Pleural effusion. Now, please tell me, if there is massive pleural effusion, what will happen to the trachea? So you see, trachea will be shifted to the opposite side. If there is massive pleural effusion, trachea will be shifted to the opposite side. Okay. Pediatric emergency, intussusception, ultrasound sign, target sign, donut sign. Comet tail artifact. It is seen in strawberry gallbladder. Ring down artifact, it is seen, let's say, if there is air pocket, if there is pus pocket or air pocket around the gallbladder, right? See here, this is comet tail. comet tail. This is comet tail. Fine, comet tail artifact. Now ring tail artifact. So ring tail artifact will be definitely longer. And they occur due to gas bubbles. Right? Occur due to gas bubble. Hounsfield unit of water, 0 Hounsfield unit. Now here you need to remember, please, all the Hounsfield units, please. No mnemonic, just remember it. Very, very important, please, on my request. So air, it appears jet black. Bone, it appears bright white. Cortical bone, 1000 Hounsfield units. Fine. Cancellous bone, 300 to 800 Hounsfield units. Water, 0. Fine. Now brain, 40 to 50. Blood, acute blood, 60 to 90. Right? Hounsfield unit. Fat, minus 100. So that is why fat appears connect to server. I think now it has started. बीच में आया था fail to connect to server. आ गया जी, है ना? I'm really sorry dear friends, थोड़ा सा पंगा आ जाता है कभी, क्या करें. Okay. Really sorry. So most radiosensitive cell cycle phase, G2M. And which phase? This is considered radio resistant. Fine. You see, G1 and G0 phase is considered intermediate. G2M phase is considered highly sensitive. Brachytherapy in cervix, key dose limiting organ is. Fine. You see, spinal cord. When we speak about the spinal cord, so spinal cord is far away. Rectum, patient can develop rectal ulcer. So this is the answer. Fine. So this is less exposed in brachytherapy. Now liver is far away from cervix, right? Thyroid, 123 versus 131. Remember, thyroid 123, what is the half-life? 11 to 12 hours, right? Here, what is the half-life? 8 days. So this is the right answer. Iodine 123 is preferred for imaging. Fine, preferred for imaging. Iodine 123. And which iodine is used for brachytherapy? Iodine 125, it is used for brachytherapy. In prostate. Now, acute aortic dissection. If your patient is hemodynamically stable. If your patient is hemodynamically stable, you will always go in for CT angiography. And if your patient is unstable, transesophageal Transesophageal echocardiography. Transesophageal echocardiography. Right? MRI contraindication, absolute. See, this is also the right answer, but then you see here they have given it non-MRI compatible pacemaker. Fine. So this can be considered second best answer. This is considered best answer over here. Claustrophobia, this is a relative contraindication. Tattoos, it is not a contraindication. It is not a contraindication. Earlier it was considered, but with the newer generation it is not considered a contraindication. Right? Now see, pulmonary edema, radiographic features are, pulmonary edema, radiographic features are, yes, anyone please. Curly B line. I'll show you the curly B lines, but first tell me, where do you get to see deep sulcus sign? Where do you get to see deep sulcus sign? You get to see in pneumothorax. You get to see in pneumothorax. Cavity nodule and pneumatocele, you get to see in tuberculosis and trauma. Tuberculosis and trauma. Yes. So these signs are important. So we'll just spend 20-30 seconds reading these signs. 20-30 seconds reading these signs. All the heart signs, they are important. Right? Now see, these are the heart border. These are the heart border. Which structure does not form any heart border? It is the left atrium. Left atrium does not form any heart border. Left atrium does not form any heart border. That's a question there, right? Left atrium does not form any heart border. Okay. Then egg on the string. Egg on the string, it is seen in TGV. Transposition of great vessels. Transposition of great vessel. Egg on the string appearance. Egg on the string appearance. Right? Transposition of great vessel. Boot shaped heart. It is seen in TOF. Tetralogy of Fallot. Fallow. Whatever you want to call it. आप थोड़े अंग्रेज हैं तो फैलो बुलाएंगे, थोड़े मेरे जैसे हैं तो फैलेट बुलाएंगे. Fine. So if you see, there is calcification. That is called as egg in the cup sign. So this is seen in constrictive pericarditis. If you see peripheral kind of thickening, peripheral calcification or peripheral density, density is a better word. Egg in the cup sign. Box shaped heart. Box shaped heart. Fine. You see here. So total anomalous circulation. Total anomalous circulation. Box shaped heart. Fine. So Epstein anomaly. Epstein anomaly. Box shaped heart. Figure of 8. Snowman heart. Total anomalous pulmonary venous circulation. Total anomalous pulmonary venous circulation. Figure of 8 heart, also called as snowman heart. Yes, Epstein. Yeah. Water bottle sign. It is seen in pericardial effusion. Pericardial effusion. Water bottle sign. Water bottle sign. Yeah. Snowman, figure of 8, both are same. Now Schmitter, ये जो चाकू है, ये जो तलवार है, that is called as Schmitter. Fine. So this is seen not in total, but it is seen in partial anomalous pulmonary venous circulation. Partial anomalous pulmonary venous circulation, right? Because ये heart signs बार बार आते हैं, थोड़े से पढ़ने इंपॉर्टेंट थे अपने लिए, right? Bone metastasis, osteoblastic pattern is typically seen in, what is the mnemonic? PCM. So osteoblastic typically are seen in prostate cancer, carcinoid, medullary carcinoma, of the thyroid, fine, prostate cancer. Now multiple myeloma, remember they are lytic. What do we get to see? Raindrop skull. Thyroid follicular carcinoma, purely lytic. They are called as pulsating secondaries. Renal cell carcinoma, purely lytic. Acute appendicitis, first line imaging in adult non-pregnant. So you see, first imaging is generally ultrasound. What is the investigation of choice? Investigation of choice is contrast CT. Investigation of choice is contrast CT. Investigation of choice is contrast CT. First investigation generally is ultrasound. What is the investigation of choice? Contrast CT. Why ultrasound is not chosen at the answer? Because it says ultrasound always. No. First investigation ultrasound, then you have to go in for CT. Right? So ultrasound always. If you remove this always word, then the answer is C. But because they have used always, I will go in with B as the answer. Okay. First investigation ultrasound. Investigation of choice contrast CT. Okay. Just give me a minute. Okay. So radiotherapy, high dose rate versus low dose rate. What is the key difference? High dose rate cannot be kept inside the body permanently. Low dose rate, yes, it can be kept in the body permanently. Fine. High dose rate uses high activity source with short dwell time. For example, external beam. It delivers high dose in one single session. What is low dose? You keep needles inside the prostate. Slow dose of radiation, right? Nuclear medicine, PET tracer for infection or inflammation. PET. Positron emission tomography. Answer is 18. Fluorodeoxyglucose. Why? Because it accumulates in leukocyte apart from malignant cells. Now 99 technetium MDP, it is used for bone scan. Fine. MIBG, this is used for neuroendocrine imaging. For example, if you want to have a look at pheochromocytoma suspect, then you will go in for MIBG scan. contrast SF6 bubble, sulfur hexafluoride bubble. So inert gas in lipid shell. So contrast enhanced ultrasound, it is used for liver lesions. It is used for liver lesion. Classical sign of sigmoid volvulus on X-ray, coffee bean sign. Crescent sign, it is seen on X-ray in intussusception. String sign when it is seen in the ileum, this is seen in Crohn's disease. When it is seen in the pylorus, this is seen in infantile hypertrophic pyloric stenosis. Target sign, it is seen on ultrasound in intussusception. Right? 62-year-old male with long standing hypertension presents with progressive dyspnea, orthopnea and bilateral pedal edema. Chest X-ray reveals cardiomegaly, upper lobe venous diversion. Fine. So this is stag antler sign and bilateral pleural effusion. On HRCT, which of the following findings are most characteristic of pulmonary edema? Most characteristic of pulmonary edema. Which of the following findings are considered most characteristic of pulmonary edema? Centrilobular nodules, tree in the bud. So you see they are seen in COPD. They are seen in COPD. So wrong. Smooth interlobular septal thickening. These are curly B line. Curly B lines. Fine. The rest of them are also seen in COPD. Also seen in COPD. Very quickly, let us see both. Now, aortic dissection we have already seen. See here. So, you see, first image absolutely normal. Fine. Second image, stag antler sign. You get to see bronchovascular markings in the upper regions. Fine. Prominent upper zone vessels, stag antler sign. Then you get to see horizontal lines. So these horizontal lines, they are called as curly B lines. Then your patient develops bat wing edema. Now, what are these? Please tell me, what are these? Anyone? What are these? So these are stainless steel sutures used for closing sternotomy. They are used for closing sternotomy. Right? This thing we can see later. Nevertheless, I will share this PDF, but then first let's quickly finish the questions. Radiation safety. What is the most effective way to reduce operator dose in fluoroscopy? So fluoroscopy is also called as cine X-ray. Increase distance from the source. Fine. If you increase distance from the source, everything will become fine. Radiotherapy emergency, spinal cord compression imaging. Fine. So that means we are talking about cauda equina syndrome. Cauda equina syndrome. MRI, whole spine. MRI, whole spine. MRI is the investigation of choice for PIVD. Contrast reaction. Pre-medication helps mostly with, fine. Physiochemical toxicity, no. Delayed T-cell reaction, no. This is the right answer. Pre-medication also helps with contrast-induced nephropathy. Pre-medication means you give your patient antihistaminics and IV fluid before you give contrast. It will protect against both C and D. Both C and D. Then this is a repeat question. LRA, as low as reasonably achievable. Testicular torsion, first line imaging is color Doppler. First line imaging is color Doppler. Fine. First line imaging, color Doppler. Mammography, feature suggestive of malignancy. Spiculated margin, round circumscribed mass is going to be fibroadenoma. Coarse popcorn calcification is going to be involuting fibroadenoma. Fine. Fat containing lesion, it could be lipoma or fat necrosis. It could be lipoma or fat necrosis. Repopulation effect, always beneficial for tumor control, causes treatment acceleration. So basically repopulation of normal cells, that is what we are speaking about. B is the right answer. Okay. Emergency radiology, tension pneumothorax is a clinical diagnosis. Fine. So needle decompression without any delay. If you do the ultrasound, what will you get to see? You will get to see stratosphere sign or barcode sign. Must keep in mind that seashore sign is normal. Seashore sign is a normal finding. CT scan, chest is being viewed to assess lung parenchyma. Fine. Now, imaging appears too bright and much of the lung detail is lost. So this question is on CT windows. Now this is based on Hounsfield units. Lungs, they are full of air. Fine. So CT value this. You fix it around -600. Fine. -600. So Hounsfield unit of lungs, right? So Hounsfield unit of lungs, they are around -650 to 900 Hounsfield unit. So you will fix it in the below range, right? In the negative range. This is good for bones and soft tissue. Fine. Again, this is also good for soft tissue. This is good for bleeds. Hematomas. If you have to see the lungs, naturally you have to go in for, the negative Hounsfield unit. Now here, this is one liner. Microhemorrhages, diffuse axonal injury, SWE sequence. Fine. Susceptibility weighted images. Which sequence suppresses CSF? Which sequence suppresses CSF? Fluid attenuated inversion recovery. Fluid attenuated inversion recovery. Okay. So periventricular, that means around the ventricles. So this is used for MS. Okay. Sequence used to detect fat in adrenal adenoma. So fat is suppressed with gradient echo. Fat is suppressed with gradient echo. Sequence used for edema in brain tumors. Flare. Fine, flare. Brain tumor. Sequence that suppresses fat by inversion recovery. Short tau inversion recovery. So that is used for stress fracture and osteomyelitis. Osteomyelitis. Fine. Osteomyelitis. Short tau inversion recovery. Short tau inversion recovery. Sequence most affected by susceptibility artifact, gradient echo. So if there is a metal substance nearby, gradient echo images will be very poor in quality. Fine. Okay. Early cortical laminar necrosis. Anatomy will be changed forever if any part of the brain dies. And which sequence is best for anatomy? T1. T1 is the best sequence for anatomy. Multiple sclerosis. Which investigation is best in case of spinal cord lesions? T2. Sagittal. Again, this is you'll have to remember. Now, bright on T2 and dark on ADC, that is infarct. But bright on T2, bright on DW1, but ADC is normal. ADC is normal. No infarct. First of all, it is not an infarct. It is not an infarct. Everything is normal. Everything is normal. So this is T2 shine through. T2 shine through. See, if it is an acute infarct, it will be bright on DWI and it will be dark on ADC. But what does it say? ADC is normal. So it could be anything but not an infarct. इतना भी आपको मालूम है अगर, तो इस एग्जाम के लिए परफेक्ट है, ओके है. और नहीं भी आगे वाला याद करेंगे चलेगा. बस ये याद रखना है कि infarct has to be bright on DWI and dark on ADC. Okay. So these are just one liner. For CSF leakage, which sequence? T2 drive. For CSF leakage, T2 drive. MRI sequence which is prone to the shift, gradient echo. When I spoke to my PG resident here, every PG resident is my senior, so they just told me that GRE is based on older technology, SWE is based on newer technology. Fine. So GRE is prone to artifact. GRE images are not very clear. Fine. Whereas the SWE sequence images are clear. SWE sequence images are clear. Fine. करना बहुत कुछ था आपके साथ, बट समय थोड़ा सा कम है. Right? Nevertheless, I will share all these images, all these notes with you. Right? So wishing you all the best. मेरी अगली क्लास का टाइम हो गया हुआ एक्चुअली. So wishing you all the best for your exam. सब अच्छे से एग्जाम करो, 200 से ऊपर नंबर लेके आओ, and then do your internship and clear the PG exam also, right? So I have to end the class as of now, and here I am wishing you all the best for your exam, right? आराम से करो, जो जबरदस्त तरीके से करो. पास तो होना ही होना है, बस 200 से ऊपर नंबर लाने की कवायद करनी है.